I'm David Engman from Cedars-Sinai Medical Center, and with me today is Dr. David Hale from ThedaCare, New London Hospital. Today we're going to present information on a new host response assay that helps to distinguish bacterial from viral infection. Our presentation is sponsored by DiaSorin, but our views represent us, David Engman and Dr. Hale, not those of Cedars-Sinai Medical Center or ThedaCare. It's based on our experience with this assay and that alone. An important challenge that faces physicians every day, in particular emergency department physicians, is how to distinguish bacterial infection from viral infection in patients who present with signs and symptoms of acute infection. And the challenge, of course, is that today's methods are imperfect. In particular, there can be prolonged time to results. Often the site of infection is either not known or inaccessible. A big problem that everyone's aware of is that the pathogen is not often detected, especially with the low sensitivity of blood culture, which is a gold standard for bacterial diagnosis and pathogen identification. Sometimes the rapid test will identify a viral pathogen, but there may be a bacterial and co-infection present. But sometimes physicians get that viral diagnosis and hang their hat on that when they make treatment decisions. And finally, a commensal organism may be detected. And even though the lab and knowledgeable clinicians will be aware of the common commensal organisms, sometimes there's overlap between pathogenic and non-pathogenic commensals. Another important factor that is not as much discussed is that infectious disease can be in the differential diagnosis of many non-infectious diseases, patients who present with signs and symptoms of a cardiac event or a neurologic event. Infections can cause those same symptoms, and sometimes antibiotics are prescribed to cover for those lower probability contingencies in those patients. So now enter the test we're going to discuss today, which is liaison MeMed-BV. This test was developed by an Israeli company, MeMed, and then adopted to the high throughput platform by DiaSorin company called the Liaison family of instruments. So this test can be run on a small instrument called the MeMed Key or the large high throughput instrument, the Liaison XL or XS. This test takes advantage of the differential immune response to infection that we all make, depending on whether the pathogen is viral or bacterial. And it does not really involve detection of the pathogen itself. However, a very interesting factor in our host immune response to infection is that when we're infected with a virus, we produce a set of molecules that is distinct from that produced when we're infected with bacteria. And the signals that a viral infection induces are elaborated both in the messenger RNAs or the gene expression response to that infection. And those are also different from those that are induced by bacterial infection. So a recent trend over the last maybe 10 or 20 years has been to focus on this host response rather than bacterial or viral pathogen identification in generally distinguishing between bacterial and viral infection, because the treatments of these two types of infection generally are different. Bacterial infection is treated with antibiotics. Viral infection mostly is treated with supportive care. And so because of that, knowing the difference between bacterial and viral infection is very important. Some of these molecules are familiar to many in the audience. C-reactive protein, procalcitonin, these are well known to be associated with bacterial infection. The MeMed-BV test focuses on three molecules whose expression differs in these two types of infection. IP10, TRAIL, and CRP. TRAIL is a member of the TNF family that's important in immune response to viral infection. CRP is well known to be an acute phase reactant produced in response to bacterial infection and other pro-inflammatory stimuli. And IP10 is a chemokine involved in innate and adaptive immunity. It's these three molecules, not a fourth, not only two, but these three and these three alone that constitute the MeMed-BV signature. And the test measures the serum concentrations of these molecules, and then through an algorithm generates a score between 0 and 100 that largely corresponds to the likelihood of bacterial infection, and I'll discuss that in a minute. Upon infection, TRAIL, IP10, and CRP are all induced by viral infection to different levels, with IP10 being quite high in viral infection, TRAIL also very high, and CRP elevated, but not as high as is seen in bacterial infection. In bacterial infection, the TRAIL levels actually decreases. The IP10 is induced, but not as high as in viral infection, and the CRP, of course, is the highest in bacterial infection. It's knowledge of it's integrating the serum response in this way that the test can distinguish bacterial from viral infection. But it's not simply measuring these three and then coming up with a simple answer. What this test does is it integrates the levels of all these three in such a way that it can counteract the well-known blind spots or times when those biomarkers are not useful for bacterial viral discrimination that are seen in TRAIL, IP10, and CRP. CRP is very well known to be normal during very early infection. But because the TRAIL and IP10 are abnormal in this way that we discussed in the previous slide, the test can still call a bacterial infection even very early when the CRP, the normal bacterial biomarker, is normal. And likewise, when TRAIL and IP10 later on in an acute infection return to normal, the CRP is abnormal, and the test can distinguish that way. So in this way, over a 7-day course from symptom onset, this MeMed-BV test can distinguish and separate bacterial infection from viral infection. And this is where the real value of this test lies. The score itself runs from 0 to 100, with 0 representing a very high likelihood of viral infection or no infection. And let me just emphasize that when there's no infection, you don't get a score in between bacterial and viral. The score is the same, in the same range as it would be if there were a viral infection. When there's a bacterial infection, the score is very high. And there are moderate levels of viral and bacterial infection, moderate scores that represent a moderating likelihood of viral infection or bacterial infection. And finally, this score in between, this equivocal score, does not inform bacterial viral discrimination in any way. And in fact, scores in this region should be ignored when it comes to interpreting the likelihood of infection from this particular test. So this is a point I just want to emphasize, is that an equivocal score does not inform this discrimination. An easier way to think about it is there's a very low likelihood of a bacterial infection or co-infection when the score is low, a moderately high likelihood of bacterial infection or co-infection when the score is high, and the negative predictive value, which is where the real gold is in this test, is super high. It's over 97% when the score is low. And this is why this test is really essentially a rule-out test for bacterial infection. The positive predictive value isn't quite as high, 60 to 80%, because some certain viral infections, particularly COVID-19, or patients who are seriously ill, for example, those requiring intensive care and mechanical ventilation, often will have a high score because that effect on the body's physiology is very strong and causes immune dysregulation, leading to a high score. But if you have a high score, the default treatment is with antibiotics, which is the safe treatment for patients who have score in the high area. So the take-home message here is that a low MMBV score, MeMed-BV score, means it's very unlikely that there's a bacterial infection present. The populations that are cleared for this test are adults and children over 155 days who have suspected acute bacterial or viral infection with symptoms of infection for 7 days or less. These populations, at the time the FDA clearance was issued, had not been studied enough to have any recommendation by the FDA, but these are all areas under current study, and it turns out that it works very well in many cases of immune deficiency, malignancy, and even in patients with possible new infections. So I would emphasize also that at the moment, the clearance is for emergency department, urgent care center, or at the time of admission to the hospital. The largest study, there have been dozens of studies now, many dozens, on this test, including these very large clinical studies. And this is the one that actually was the hallmark study that led to the FDA clearance, that have analyzed the performance of this test. And to make a very large study very simple on this one slide, they studied 416 patients, had a panel of experts adjudicate based on all the clinical and laboratory and imaging parameters available, these 416 patients into bacterial or viral infection. And it was found that the negative predictive value was over 98%. The positive predictive value, as I mentioned earlier, was lower, about 59%. And this is the basic finding that you will see in many of the papers. The positive predictive value can be higher, especially if there's a higher prevalence of bacterial infection, and the prevalence can be over 80%, in fact. But this is basically how this test works and what the performance is in a general way. Now, sepsis, as many of you know, is related to but distinct from bacterial-viral discrimination. Sepsis can be viral, but often the most concerning type of sepsis is bacterial sepsis. And so this test was studied in a subpopulation of this 416 patients, in those who have potential sepsis. And what this study did, which was basically presented at the Military Health System Research Symposium a few years ago, is they took 366 of those 416 patients. So over 88% of these patients in that large study actually met a potential inclusion as in sepsis as having greater or equal to 2 Sears criteria, and did the same performance analysis that was done in a larger study. And that was found to have high sensitivity and specificity, a very high negative predictive value, higher than in the parent study, and then a high positive predictive value, largely because this sub-analysis included patients who were more ill than the general population, and therefore the test is going to perform a little better when there's a higher prevalence of bacterial infection. And it did better than procalcitonin in the AUC of 0.97 versus 0.73. So this test is not a sepsis test per se. It doesn't just diagnose sepsis or separate it from a non-septic condition, but within patients who have suspected sepsis, it can still do that bacterial viral discrimination that is so key in treating these patients. Now, what about more practical issues in the emergency department, such as return visits and hospitalization? Well, this more recent study, published last year, actually looked at this exact question. And they took 214 patients, divided them into those receiving standard of care or standard of care plus the MeMed-BV test result, and had the following findings. First of all, antibiotic prescription rate. When the score was viral, without knowledge of the score, 25% of patients examined by the physicians were given antibiotics. But knowledge of the MeMed-BV score, of a viral score, led to a 50% decrease in antibiotic prescription. In contrast, when there was a bacterial score, 41% of those patients had enough signs and symptoms or lab or imaging evidence that there was a bacterial infection present to be given antibiotics when treated with standard of care. But knowledge of the MeMed-BV test result increased the antibiotic prescription by double, basically double. Interestingly, and somewhat problematically, but some room for discussion, is that when there was an equivocal result, the prescription rate dropped by 50% as well. The numbers are smaller here, but the clinicians are not supposed to consider this result when there is an equivocal result. Nevertheless, they did in this test. But the bottom line here is that you have a decrease in antibiotic prescription when there's a viral score and an increase in antibiotic prescription when there's a bacterial score. So the test is performing in this population as it was intended. When you look at ED return visits or hospitalization within 7 days, you can see that when the score was viral, there were 4 of those patients who returned to the ED within 7 days, and only 1 in the group that had knowledge of the MeMed-BV score when the antibiotic prescription was made. In the bacterial group, when there was bacterial score, 5 of those patients, or 23%, actually returned within 7 days, and only 1 of those that had a bacterial score returned within 7 days. So these numbers are small. So this is sort of a suggestion or consistent with the idea that this test can reduce ED return visits, but it's supported by the finding that only 1 of those 4 who returned received antibiotics, and none of those, the 0 of the 1 that had the knowledge of the viral score returned. And likewise, only 1 of the 5 of the bacterial infection returned. Even though 41% got antibiotics, only 1 of those 5 had been given antibiotics, and the 1 who did return where there was knowledge of the BV score and given bacterial antibiotics returned. Interestingly, in terms of hospitalization, 3 of those who had bacterial scores but no knowledge of that score when the antibiotics were prescribed returned, and none of those three received antibiotics, as you would expect. So the actual use of antibiotics and the return within 7 days or hospitalization within 7 days is completely consistent with the idea that the test can do very good antibiotic or bacterial viral discrimination. What about experience? And I'm going to get into this with Dr. Hale in a few minutes here. And how does that experience make clinicians more comfortable with this test, and what effect does that have on their utilization of the test? Well, this was a very large study that was done at Maimonides Hospital, where they had 749 patients and 681 after excluding those whose blood culture was not processed. And they basically analyzed physician prescribing behavior or use of the test for 2 different periods. One from 2022 to 2023, and the second period from 2023 to 2024. So it was basically a 24-month study with the same clinician group using the test for that entire period. I would point out in this particular study population, 87% of these patients had negative blood cultures. This just shows how low the sensitivity is of blood culture in populations that have a decent chance of having some bacterial infection. What these clinicians found is that this is with knowledge of the MeMed-BV test, that the 80% of those with viral scores were given antibiotics, but 93% if there was a bacterial MeMed-BV score. So even these are sick patients, so they had blood cultures taken and a MeMed-BV test, so there was suspicion of potential bacterial infection, that, as you might expect, there's still antibiotic being given even though there was suspicion of, a viral MeMed-BV score. And of course, that was higher when there was a bacterial score available. In terms of hospital admissions, again, 77% of those with viral scores were admitted, 90% of those with bacterial scores were admitted. What happens when there's another year of experience? Well, those numbers change. 80.7% now drops to 60% when the clinicians have more experience with this test and know that they can rely on it more. And the 93% goes up to 98% when there's knowledge of the test and knowing that the bacterial score emphasizes or reinforces the high likelihood of bacterial infection. Likewise, when there was a viral score, admissions drops from 77 to 61%, and when there's a bacterial score, admissions rises from 90% to 91.2%. So this is just emphasizes that, like any new test introduced to the field, it takes time for people to use it, see the results, see how they're working with their patients, and get more comfortable and have more confidence in using it. So for this first introductory part, the conclusions are that the quality of the host response, that three-part test, IP10 CRP trail, can be used to distinguish bacterial infection from viral infection. There is a very high negative predictive value for bacterial infection with a very fast turnaround time. The differential dynamics of those biomarkers removes those blind spots that each one of those markers has and allows bacterial-viral discrimination over a full 7 days from symptom onset. It's extremely useful for diagnostic and antibiotic stewardship and can reduce hospital admissions and ED return visits. This issue that had the low numbers in that study, over time, I think people will see that the numbers are going to bear out with these, especially with larger numbers of patients or with personal experience at individual institutions. And finally, that utilization improves over time as clinicians learn the power of the test. So with that introduction to this MeMed-BV test, I want to invite Dr. Hale to join. And we really want to talk about his personal experience with this test and how this has been introduced into his system and used by his clinicians. So welcome, Dr. Hale. Thank you for joining me today. And I'm looking forward to this more important part of the presentation where we get a real life view of this test from an emergency department physician and leader. Can you first tell us a little bit about your background and about your roles as chief medical officer and especially the physician sepsis champion in your institution?
Sure. Thanks, Dr. Engman. So I am the ACMO and ED medical director for a small critical access hospital. And actually, I found out about this test. Our lab reached out to me. I had some interactions with them on other things and asked me about a different test. And when I looked at the data, specifically looking for some kind of a help or additional test we could look at for sepsis, in particular, the early detection of sepsis. And the particular test that they wanted to use, when I reviewed the literature, I felt it was basically worthless because it turns positive when the person is clearly sepsis. And that's not, at least from my perspective and in talking to a lot of my colleagues and those I know from across the country, the issue is not when somebody comes in and they're hypotensive or they have a known infection. The issue is when somebody shows up, then they just don't feel well. But they have a lot of comorbid factors. And people will tell you like, well, I don't know what's wrong, but they don't look good. Or they're a little bit more confused in a dementia patient. Like, what does that mean? And so really that's what I was looking for. And as I started looking at the literature and the studies that were out at the time, I felt like this would be a good test. So what we did is I am fortunate enough to be able to have close relationships with some of our ED directors, and we went to one of our flagship hospitals who was already doing a little bit more work on sepsis, and we introduced it there. And your slides are very accurately displaying what happened is that Initially, there was a lot of hesitation. Why should I use this? It doesn't do this, it doesn't do that. And the one thing, if people don't take it home anything more than this, is the test does what it says it's going to do. If you follow within the standards and you use the test as it's designed to use, it'll do what you need it to. And I just think for me, myself as an emergency medicine physician, that's really important because people will talk about white counts. And what does that really mean? Sometimes it's high, sometimes it's low. Yeah, I don't think it's that all that helpful almost every time, but this test was. So when we looked at our initial test data, and this wasn't blinded, this wasn't really trying to do any research. It was just to see what happened. And you could see that the incidence of the test got used. And when you talk to the docs that were using it, it really was that comfort with it and kind of testing the system. What are the tests? See what they do anyway. And could it have changed their decision later? And when you talk to them and then you look at their notes too, it's very clear that what happened on day one and what happened on 6 months later were different. And then you started seeing notes like MEMED BV score was 3. Um, Supports my opinion to discharge the patient home or the reverse. The MEMED test was 88 or 96 or whatever it was. And oftentimes, probably I would say 20%, just rough guess, um, made them look a little bit further and do a little bit more testing. And the anecdotal evidence for that is amazing about the number of cases that we had that extra test found something that you otherwise weren't going to find. And I'll give you an example. I had a pediatric patient, um, a lot of special needs, a lot of comorbid factors, really only could say about maybe 1 or 2 words. And it was a 7-year-old girl. Mom brought her in because she wasn't saying those 2 words as well as normal. And she was concerned that she had an infection. She had a history of infections. Usually it was pneumonia. And so we started the workup. And really everything we ordered was pretty intermediate. Her white count was minimally elevated. Her electrolytes were within her range, maybe a little on the higher end of her range, but they were there. Chest X-ray really didn't show anything. We did a blood culture. Lactic acid was fine. Um, and we don't admit pediatrics. So I called pediatrics and we talked about it, and they felt pretty comfortable that we'd done all the right tests and studies and treated the person appropriately and okay to discharge home. Um, Her MEBED score was 96. And mom was also pretty adamant that we were not catheterizing this little girl. Um, it was very helpful in that case because the discussion we had, and I think most ER docs know that a lot of parents, if not all of them, or at least most of them, fairly well educated on their kids, and they know their kids better than we do. So I usually tend to defer to them, at least to some extent. And so she was adamant she never gets them. I'm great hygiene, so on and so forth. So, all right, well, we'll hold on that. And pediatrics knew that when we were talking about it, and we all kind of thought, well, okay, that's reasonable. When that score came back, we had another discussion with mom, and she agreed to let us catheterize the little girl. And ultimately, she ended up having a UTI, and it was pretty obvious. This wasn't is it questionable? No, it was a full-on UTI. Um, and just again, anecdotal things. I have lots of cases like that. But the point was, it helped in the evaluation because it helped reassure the mom that we were doing, we're really taking what she said to heart, and we were really making sure her daughter was safe to go home. And we ended up putting her on antibiotics, got her transferred. I did a one visit follow up or one admission follow up, and she was doing fine. So, like I said, there's lots of those. I have cases where somebody comes in, they look pretty sick. Maybe they have COPD, maybe they have a little bit of renal failure. And initial thought is, oh, we're going to admit this patient because they always get admitted. And I just know from a lot of EDOcs will say the easiest admission is the patient that just had the same diagnosis the last time that they got seen and they got admitted for that one too. So it can be tend to be a little bit easier, especially when your Ds are busy or boarding and so on and so forth. And there's been 3 or 4 patients where knowing that their score was 6 or 7, um, you continue to keep them a little bit further in the ED if you have that option. And we do one because we're small. Two, because we don't often have beds, and so we're going to have to transfer, and our other hospitals are full. So those patients aren't going anywhere for a while. And you resuscitate them, you reevaluate them, and those patients go home. We don't have to try to find a bed for them. We don't have to admit them. And for a lot of reasons, that's the right choice. So just that's basically, my pathway on this. I think it's a great test. And I'll be clear, this is not the test in my mind for somebody who clearly has bacterial sepsis. It's not going to change what you do, but it's not meant to, in my mind. It's really not. It's that middle ground. Similarly, it's not used for the patient who doesn't have sepsis, although if you have a sepsis PPA, it's firing right away. And I think most people on this video will get that one immensely as it's firing, and then this is not it. Their search criteria is positive, and it's because they ran from the parking lot and they're out of shape, and their heart rate goes up, their respiratory rate goes up, and it fires. It's that middle ground where you're not sure. You think you're going to go one direction, and using this test, sometimes it really does make a big difference and changes what your thought process was.
And that middle ground isn't a small population. There are a lot of people who fit into that too, right?
No, I worked last night, and I would say we had a large outpouring of the nursing homes, skilled nursing facilities, assisted living last night, and I can tell you it was probably about 50%.
So besides children and say those elderly or with dementia, are there other types of patients who either have difficulty communicating or where this test is especially helpful when there can't be good communication?
Sure. I mean, obviously the dementia patients, but I will say, I'll give you two examples. One is a COPD patient that people like to throw antibiotics, and there's even some pathways on when you should give antibiotics and when you shouldn't. Um, and I've used that score as being negative, to hold off on antibiotics just for those COPD patients that are going to either be discharged or be admitted. And when I follow them up, because again, as I said before, you want to make sure what you're talking about and what you're doing is actually matching what the patient is. So you do some follow up. You check the system, see if they followed up in the clinic, see if they came back to the hospital, and they don't. They don't. They don't come back. If they do come back, it's not a bacterial infection. It's something that's unrelated. So I would say that I had a patient last night that came in that becomes hypoxic primarily because he doesn't take his meds. He's got a little bit of underlying dementia, but normally he's self-sufficient. Came in last night because he hadn't been taking his meds again. His initial two sats were 75% on room air. He's not normally on oxygen. And working him up and looking actually at what had happened the last time, he didn't have a bacterial infection, but this time and they didn't do the score. So I don't know what it would have been at that time, but I know at this time that score was elevated. And honestly, his chest x-ray was essentially worthless. He was slumped over, even despite us trying to hold him up. His lungs, you couldn't really see him, but we went ahead and gave him some antibiotics. He ended up on BiPAP. We transferred him to the ICU in one of our hospitals. They were able to get a CT scan, and there was pneumonia, which he didn't have the last time. So if I had just, was real busy, and the easy answer is, okay, he's stable, he's breathing fine. His white count, I think, was like 8, so it was not elevated. He had some AKI. But the easy answer would have been to say, all right, I need to get you out because I've got a lot of other sick people, and I have a ICU waiting for you. But that's also took probably maybe an hour and a half, 2 hours, which I consider good to get him to an ICU bed. And that's 2 hours or 1 hour that he's not on antibiotics that down the road you find out that he actually would have benefited from them.
So, in terms of that issue and the operational aspects of this test, have you found that logistically the turnaround time or your interaction with your laboratory is sufficient to use this test effectively?
Yeah, ours takes maybe 50 minutes roughly. for that test to come back. And the patients that I'm considering and I'm looking at, maybe 80% of the time, they're not going to be going anywhere in an hour. That is not slowing down anything. I'm not waiting for that one test to make a decision. Those patients that are obviously need to come in, they're kind of on the fringe of whether I even need that test, but those might leave before when we're not full upstairs. So yeah, I don't, for me, it's not a rate limiting factor at all.
When you rolled this out to your clinicians, what kind of education did you provide about this test? You mentioned that there was some hesitancy at the beginning, as is natural for any new test. Um, but is the education process challenging in particular, or what else? How did you do that actually in your system?
So in a word, I would say it's ongoing. I had some of the slides, I used some of them, reached out to individual doctors. We have a couple of big group meetings, presented it there, answered questions, excuse me, and then looked at the data. And those docs that weren't using it, the question I had is why not? Why aren't you using it? Is there something more? And again, some of that, the initial answer is, well, it's not going to change my mind. And you start talking about what their colleagues are doing, and it does change their mind. And once you can get someone to try it, it's a test that's covered by insurance where we are. So you're not adding in a huge amount of cost, and it's certainly not a lot of cost to the patient. And I look at it, if I'm already ordering $4,000 worth of lab tests and x-rays and CAT scans and whatever it is that I'm doing, I feel like adding an extra $60 or whatever it ends up being at a person's facility is worth the bang for the buck. So it's just showing them and getting them to try, and even just saying, well, order the test on, like, let's say the next 10 to 20 patients. Before you find out what it was, write down what you think should happen, and then look at what happened and see if that changed your mind. See if that made you want to look a little bit more. It's kind of like when we used to do VQ scans where you had to try to decide there was a PE before you did the scan, because if you do it afterwards, it's not really how it was supposed to be done.
Right.
Just like you show those markers is actually funny. I think we were talking about this a long time ago, but you see the three spikes in the tests and when they're positive, when they're not. And it reminded me back in the day before we had our troponins and we were using, the various cardiac markers. Well, if the chest pain started with this one's good. And if it started with that, use that one. And not that this is troponin, it's not there yet, but it is taking one test instead of trying to blend two, three, or more tests into trying to figure out what one test can give you an answer for. And I think that's important too. I don't need to be looking at 8 different tests to figure something out if I got one that can do it for me. And the last thing I'll say is a lot of like procalcitonin and CRP and things, those are send outs for us. So they're not coming back anyway. And so that's going to be hours before that test comes back. Where in our situation, it's about 50 minutes.
Have you ever experienced where you were considering a more costly or invasive test, or even a CT, where you might get this test result and it might save you from doing a more expensive test?
I think the best example I can give is in a person that I think is sick. I don't really have a source. Um, it's kind of on the edge of whether I'm going to keep them or send them home. They look sick, but not that sick, but they also have comorbid factors. And so just kind of adding everything up, I'm not really sure. It's a respiratory complaint, and the chest x-ray comes back with the ever famous radiology reading. Um, could be infiltrate, could be atelectasis, could be inflammation, could be whatever it is they're going to come up with. And in those cases, um, there's probably been a handful, if not more, where based on the score, I either decided, well, the score is 99, we're going to treat for pneumonia, or this score is 4, I'm not going to get a chest CT and try to prove a point when the patient, I think, with that knowledge and being comfortable that that chest X-ray is not pneumonia, that they can go home and follow up. You know, I wouldn't say follow up in 2 months, but as long as they can get some follow up, I think that's reasonable. So I have used that test for things like that.
Yeah. What questions remain about this test based on your experience to date when you look forward about this test and how it could potentially be used, maybe even on the inpatient side? I mean, the receiving physicians are aware of this test, I'm assuming too.
They keep asking for when can they get it because they want to order it in those cases where it wasn't ordered from the ED. So if you had the ED physician to admit the patient, they want the opportunity to be able to order that because, as you said, blood cultures are not going to be all that helpful most of the time, and so they've asked about it. One of the things that I would really like to, not being an academic center, um, it's really a time constraint at this point, but what I'd really like to see is do a nice study on urinary tract infections in the patients with chronic Foley catheters or indwelling devices and do a study with that to see, is this really colonization or could it still be UTI on top of colonization? Or is it just a simple UTI? I guess that would be the one thing that just comes right off the top of my head. It would be nice to have that information because I just personally, it's hard for me to send home somebody who's got a fever, who's got an elevated white count, who is in a skilled nursing facility that has ability to take care of them, but they're not all great. And to be able to, it's hard for me not to start somebody on antibiotics. And maybe that's just my age or who knows, but when I have no other source for this fever. And now you're telling me I'm going to send home and wait for a urine culture, which could take maybe a day, maybe longer. Um, that's really that's tough for me to do. So being able to say, well, and the score was X, I feel comfortable with following that pathway. I think it's easy for non-clinicians and some of the microbial stewardship people who aren't ultimately responsible for these patients to say, well, you should do this and this and this. And my response is, I hear you, I see the data, but there are select patients where you're not the one that's taking care of this patient. And if there's a bad outcome, I'm the one that's going to have to talk to that family about how I missed that opportunity to maybe make a big difference in that person's life. So makes me feel a lot more comfortable at the end of the day. And I learned that as a resident, the one thing you don't want to do is go home and say, I wish you would have done this. Those are the persons you will notoriously look up the next day and then follow. And then, oh, did they go to the clinic? Did they get admitted? Did they die? Um, and that's just something that I would used to eat on me until I changed my practice as a resident. It's like, don't do that.
Any final thoughts before we close this session?
Like I said, I think it's a great test. I think that this will probably be improved over time. Our data will get cleaner and probably expand. And if what I would say, if people have an opportunity to use it, test it. You'll see.
Thank you. I would just say, as a lab person who follows new uh, testing, evaluation, and in some cases, incorporation into clinical practice, that it's been interesting watching this test develop. And now someone like people like you are actually doing real world implementation and getting the results that have more practical meaning for the field as we proceed with evaluation of this and other tests like this. So thank you very much for joining me today. Thank you, audience, for tuning in. And I think we'll close there. Thank you.